Hi, welcome. I'm here at ASH and I'm here to tell you some very exciting news about checkpoint blockade in Hodgkin lymphoma. There have been two very exciting studies that were presented in the session today on Monday morning at 10:30 looking at checkpoint blockade therapy in Hodgkin lymphoma. So we'll take them in turn. The first abstract, of which I was the lead author, looked at the novel combination of the two checkpoint inhibitors, nivolumab and ipilimumab, combined with the antibody-drug conjugate brentuximab vedotin in relapsed and refractory Hodgkin lymphoma. These were arms G through I of a multi-center phase 1/2 ECOG Akron-supported NCI-funded study. And the earlier doublets had looked at the combinations of brentuximab and ipilimumab and brentuximab and nivolumab. So this was the triplet combination of the three drugs given together. The rationale for this combination is that T-cell dysfunction may be as a result of anergy or inhibition, and treating with ipilimumab and nivolumab synchronously can both activate T-cells and remove their inhibition, while brentuximab vedotin will target the T-cells directly, both reducing tumor bulk and increasing antigen, which can further stimulate the immune system. 22 patients were treated on these three arms of the phase 1 study, and we began with a dose of brentuximab vedotin at 1.2 and escalated to standard dose brentuximab. We gave standard dose nivolumab, and we gave just a very small dose of ipilimumab, 1 milligram every 12 weeks. In general, this regimen was very well tolerated. All of our patients had relapsed and refractory Hodgkin lymphoma. They could have any relapse. They needed to have normal organ function, but we allowed patients who were HIV positive if they had well-controlled HIV, and patients who were otherwise well and fit and had healthy lungs. In general, this therapy was very well tolerated, and most toxicities were grade 1 or 2. The most common toxicities were grade 1 to 2 fatigue, diarrhea, and nausea, but all of these were very well controlled. We saw grade 3 toxicities in a very few patients. One patient had diabetic ketoacidosis. One patient who was post-allo transplant had one patient who was post-allo transplant had reactivation of GVHD, or Stevens-Johnson syndrome. We also had one patient who had pancreatitis, one patient with colitis, and one patient with grade 3 arthritis. Most patients with grade 3 toxicities were able to stay on study. This regimen, the combination of brentuximab, ipilimumab, and nivolumab, was highly active. In the full 22 patient population, the overall response rate was 84%, with a complete response rate of 72%. We had 3 patients who were unevaluable for response, and the reasons they were unevaluable: one patient came off study for personal preference. They had an anaphylactic reaction and didn't want to be on a clinical trial anymore, and 2 patients came off for toxicity. For all 19 patients who had at least one staging scan and had received 3 or more cycles of therapy, the overall response rate was 95%, with a complete response rate of 84%, and one additional patient had stable disease. If you look at our waterfall plot, which shows the degree of benefit, every patient on the study had clinical benefit. With a time to evaluate progression-free survival, a median PFS duration of 0.75 years, our progression-free survival has not been reached, and only 3 patients have relapsed. In our overall survival analysis, at 1 year, no patient has died. We compared the outcomes of patients who went on to stem cell transplant with patients who remained on study, because we wanted to ask the question of whether patients who didn't get a transplant did as well as patients who did get a transplant. Roughly 40% of the patients who enrolled in our study were post-transplant, so they did not get a further transplant. An additional 1 or 2 patients opted not to get a transplant. And what we saw with a follow-up duration of approximately 1 year is that the 2 arms appear comparable. These are small numbers. We also looked across all 3 arms of the study, and we saw that the brentuximab and ipi PFS at 18 months is about 35%. The brentuximab and nivo progression-free survival at 15 months is approximately 60%, and the brentuximab ipi nivo progression-free survival at 18 months is about 80%. So this is very, very exciting data. We're really excited about both the activity and the potential durability of this data. We're currently investigating the question of whether the triplet is better than the BV-Nivo doublet in an ongoing NCI-CTEP-sponsored clinical trial randomizing patients to either the doublet BV-Nivo or the triplet BV-Nivo, and this is open throughout the clinical trials network. So if you have a patient who is with relapsed Hodgkin lymphoma who is interested in participating in this trial, please contact either ECOG-ACRIN or the Clinical Trials Network, and I am sure you will find a site near you that will have this trial open.